Thank you for the reminder. That's Wendy Rico, our patient advocacy manager. So chances are if you reach out to us or have any questions about support, you'll be chatting with her. So as I said, my name is Elizabeth Hamburg. I'm with the Joe Negro Foundation. And our goal is to connect aneurysm, AVM, and stroke patients with the community education and resources they need to help them thrive, while also funding critical medical research. Our impact, so we're actually celebrating 15 years of research, support, and awareness. And since our inception, we've been able to create, largely in part to our founder, Natalie Negro, a 24/7 global support community across the nation and really the world. We have people all over the globe of 20,000 individuals. And then we've also, this year alone, have contributed $70,000 in medical research grants. And over $4.5 million to research awareness and education since our inception. And then we have an in-person and virtual support groups across the nation and Canada. So if you're not already a part of those, we'd love to invite you to join us on those. And Wendy is going to go ahead and put the links to that information in the chat. So we have online support groups for survivors, caregivers, for parents, for honoring the taken, and for young adults that we'd love for you to join, whichever one is most appropriate for you. And then on top of that, we'd love for you to be a part of our in-person or virtual support communities. And again, Wendy's going to share those with you in the chat, and then we'll also be emailing those after the event. So we hope that if you're not already a part of those, that you will join them. And if you are a part of those, thank you so much for being a part of what we do. And we encourage you to just continue to get involved in those and be active and share your story. Our 2023 research grants, I won't read all of these, but I'll just say that it's so important to us that we're funding research that has the capability to change the way that aneurysms and AVMs are found and treated and betters the lives of patients and their family members. And so these are the physicians in the hospitals that we're partnering with, and we're really grateful for that, just to be a part of those. So you can kind of see what we're doing this year alone, and we're actually in the process of funding additional research for next year. So we're reading through proposals right now. And then, and so a couple more things. I know we've had a couple people join us. So if you haven't already, throw your name and what state you're joining us from in the chat. And we'd love for you to join our support groups. And also, I just want to present, I'm really excited to partner with Imago Rehab. So Imago's passion and commitment to excellence, innovation, and especially accessibility made us so excited to partner with them. We're really grateful for their generous support of our AVM Awareness Month, and we're excited to present this webinar, Rethinking Rehabilitation, Improving Function and Inspiring Hope. So Kristen Nichols is co-founder and chief clinical officer of Imago Rehab and doctor of occupational therapy. We're so excited to for you to hear from her today. We know she has some really practical tips for stroke survivors and just some great information to share. So without further ado, I'm going to stop sharing my screen and pass it over to Kristen.
Great, thank you. I will go ahead and share my screen. I'm, interestingly enough, wearing the same outfit essentially as this picture, which is kind of comical and unintentional. Apparently this is my presentation outfit. Yeah, thank you so much for having me on today. I really appreciate that. I want to make sure, hang on one second. So I just want to do one thing. I'm trying to make sure that the little, there it goes. I couldn't make the screen go away. Okay, we're good now. I'm gonna get started. So I wanted to just basically start out by saying that stroke does not discriminate. People who experience strokes come from all walks of life. And I'm going to introduce you to 3 stroke survivors today during the beginning and sort of the end of this presentation. I'm going to play a little video for 2 of them. So the person to take a peek at there is in the middle. Her name is Susan, and she is a professional musician. And after this video was taken, not directly after, but in the coming years, she was affected by a stroke. We also have young people that are affected by stroke. We have athletes, right? People who, you know, seem to be in the prime of life, seem to be in perfect physical condition, can still be affected by stroke. We have students. We have a lady there in the graduation outfit named Maddie. I'm going to introduce you to her. So she was affected by stroke, actually by an AVM. So what happens, you know, when these people who are just out living life, people who are seemingly incredibly healthy, have a stroke, what happens to them? So as I said, Susan is a professional violinist, and on her website, we can see that her music right now and really her life are on hold. And I have permission from all three of these folks, of course, to share their story, and I'm so grateful to them for allowing me to share their story. For Jack, he went from being a college athlete to suddenly becoming a stroke survivor. So I'm going to share a lot more about his story. And Maddie as well. She actually knew, she's one of those folks who actually knew she had an AVM and then went to have it repaired and it ruptured. And so that is what caused a pretty massive stroke for her in her early 20s. Okay, so I'm really grateful to them for sharing their stories, and I'm gonna go back to them at the end, and we'll see kind of what does rehab mean for each of them. All right, and I'm gonna do a little bit of discussion about stroke on a global scale here, noting that World Stroke Day is October 29th, which is coming up really soon. I believe that's next Sunday. So keep an eye out for some promotional materials about World Stroke Day and really spreading awareness. But we know that stroke is a global problem. If you look actually at that graphic of the world there, the blue, which we see in North America, parts of South America, Europe, India, and Australia, New Zealand area, that's actually a lower incidence of stroke. So we know there's 800,000 people in the US every year that are affected by a stroke. That is actually some of the lower incidence when we look at stroke on a global scale. You see there parts of South America, Africa, and then lots of Asia. Those you're seeing the yellow and red, so they're actually having a higher incidence of stroke. It's an even bigger problem in other parts of the world. So stroke is the leading cause of disability, second highest cause of death, and really the risk for stroke has increased by 50% over the last 20 years. So stroke is going to touch all of us. If it hasn't already, it's going to touch either our lives or someone very close to us. 1 in 4 people is predicted to have a stroke in their lifetime now. So these numbers are just continuing to increase. So the good news about stroke care is that more people are actually surviving strokes. So people were in the past dying from the initial stroke at a higher rate than they are now. The not as good news there is that it means more people are living with really severe disability from stroke because they survived that event. That little acronym there, DALY, is disability adjusted life years. So that means like all of the years that someone might live after their stroke, they're actually experiencing disability during that time frame. So what we want to do is improve those disability life years, help people to live fuller lives with a better recovery. So I'm going to explain a little bit about what traditional stroke recovery looks like, and then talk about how Imago Rehab is trying to improve upon that model. So in a traditional stroke recovery, the green is sort of indicating, you know, what your arm function might be. It's good, it's high. You can do all the things you want to do with your arm. And when the stroke happens, that function or that ability drops, right? And so your arm is no longer responsive, it's not working. The red line is sort of that stroke recovery curve. So we see usually some good improvement right away, and then it begins to taper off, and maybe it gets worse again many years later. So we see the gray at the bottom, that's the intervention. So in inpatient rehab, when you're still in the hospital, you're getting lots and lots and lots of therapy, and stroke recovery is your life at that point. You're in the hospital, you're not going anywhere else, you're there to get better. Nothing else matters. People are not working, people are not having to cook the meals. The only thing they're doing is making their life therapy, right? And then as you get home, that sort of focus on stroke recovery changes because we have other roles and routines in our life. We have to get back to work. We might have to help parent children. We might be studying for school. So there's all kinds of reasons why people aren't able to do as much therapy in that time frame. I'll get into that in the next slide as well. On the left-hand side, I have some suggestions of what usual care is like. Very exercise-based care, where we lead you through a series of movements or exercises to make your function better. We give you a paper-based home program. If you've ever lost a home program before you got home, raise your hand. I certainly have. So that's kind of a flaw in our system. And then also there's minimal carryover to the home setting. So the therapy happens in the clinic, and when someone gets home, they kind of say, check mark, I did the work, now I'm gonna rest, right? And so that's kind of a picture of what your traditional stroke recovery looks like. So some of the issues with that is that really folks are not getting enough therapy to make them better. In a recent study by Kramer, I believe 2019, they surveyed about close to 1,000, about 750 clients with stroke, and found that a month following stroke, so only 1 month later, these are folks who are now home from the hospital, only 2/3 of them had received some therapy services, and 1/3 had received no services yet. So this is kind of the prime time. We don't want to waste those moments. We want people to get right into therapy. We're finding out that not even everybody got therapy right after their stroke. Within 90 days, so in the first 3 months following stroke, these clients, these 800 people, had only received 6 to 8 sessions of therapy. So boy, not very much, not enough to really change the brain. And after 3 months, they had only received another 0 to 1.5 sessions. So, is it any wonder that that recovery begins and then tapers off when our intervention amount goes way down? So why such little amounts of therapy? First and foremost, accessibility is the problem. So only 30% of individuals following stroke return to driving. I don't have specific numbers on brain injury, but I assume they are similar or potentially lower. So folks have a hard time getting to therapy services. Typically, outpatient neurologic therapy, so therapy for people who've had a stroke, really is at an outpatient clinic attached to a hospital. So if you're not close to the hospital that has the good care, what exactly are you supposed to do? Who do you go to when you can't get to, the specialist who does this work? Next is really the cost of all of this therapy. So it's, getting a ride there or being able to drive yourself when that happens. Is there neurologic care in your area that you can actually get to? And then last, right, how much does it cost? Do you have therapy benefits in your insurance plan that are going to cover this? Or is that going to be out of your pocket? What's going on? So really, we move from that intensive immersive therapy to really sporadic care that we're trying to stretch, over a long time to try to make these gains. So, you see the green line of things getting better, and then really that taper, the dreaded plateau. If you've ever heard that you've plateaued in therapy or that someone's plateaued, is it any surprise when we, give less therapy than is going to be effective? Are we surprised that plateaus happen? So let's, are you ready for a better vision for stroke rehab? After all of that, I know that I am. So I'm going to explain what we are trying to do at Imago Rehab. So we are trying to actually change the direction of that curve by providing home-based wearable technologies, digital therapeutics, and activity-based therapy. So very different approach from exercise-based clinical therapy. So we were trying to do home-based, digital, and activity-based therapy. that comes at individuals with stroke and brain injury at a much higher rate than the traditional method allows us to do right now. So we see a lot of that area at the bottom that was sporadic care and then nothing essentially for as long as someone lives. We want to fill that in with virtual care and wearable technologies, and then or virtual care for a long time. We're trying to change that trajectory. So I'm going to explain a little bit about all three of these things. I've got a good number of slides about a variety of home-based wearable technologies that Imago is that are in our pipeline, as well as a couple of brief words about digital therapeutics. And really the point of that is to improve that paper-based home program, please do these exercises, and to give people something much more robust and engaging to work on. Then lastly, I'm going to show you Maddie again, who is really the queen of activity-based therapy. So she is not doing only exercises. She is using her arm to actually engage in tasks at home. That's the bread and butter. That's how this actually gets better. All right, so my videos want to play themselves 1,000 times. Okay, so what is really needed to change the brain? What do we need to provide people in order for them to get better? Definitely, we know people need to have more therapy, right? I'm going to just explain kind of two studies that are in literature that tell us how much therapy is needed. The image on the left is from a study that probably all stroke researchers know about, which is how many times does someone move their arm in therapy? So an average of all of these observations of therapy sessions that were intended to make the arm function better, the person was only reaching their arm around 30 repetitions per session. So is 30 repetitions enough? Is that good? The image on the right side in the blue is a rat-based study by a group by Jeffers, and they found that the patterns that the rats used using their arm to reach for snacks, which rats like, they found that if they reached 300 times, that was when the brain began to change. So their stroke symptoms got better if they reached 300 times. Humans are only reaching 30 times, but we need to be reaching, for our brains to get better, we need to be reaching 300 times per session. So we have a bit of a problem in terms of dosing in therapy. So this is called dosage. How much repetition are people getting? Answer is not enough. Okay, so we need therapy to be much higher dosage. It needs to be a higher intensity, which means more times that therapy gets to someone, and very difficult therapy, right? He also needs to be interesting. We want therapy to be to capture your attention and to make you wonder what's going to happen next, and for it to be kind of fun and engaging. So lots of things need to be better for therapy to be effective following a stroke or brain injury. Okay, so I'm going to tell you now about a study in which things went really well and people actually had a really great recovery. So I want to discuss what is that like? What has to happen for the recovery to actually be really good? So I'm going to explain some of that. This was a study that took place in Florida, and they had people with chronic strokes. They were at least 6 months 6 months post-stroke, meaning that they really weren't expected to get better on their own anymore. So it wasn't going to be what's called a spontaneous recovery. These are people who their injury wasn't going to get any better without some kind of intervention. They had moderate spasticity, which means they had quite a lot of tightness. Okay, their muscles are not moving well. And what they provided to them was a really high amount of technology-based care with arm and hand robots in a clinic, and also functional electrical stimulation. They also had folks in groups of 3 to do their intervention. So they partnered them up with each other to work together and kind of feed off of each other's energy. So these are all sort of important parts. They weren't alone, and they had really interesting care using a variety of technological devices. Okay, so what went well? On this list here, that remember that curve earlier where they got better and then they sort of didn't get better anymore? These folks are in that red tapering off to getting worse period. But what do we see here? We actually see that black line is shooting up. They had a fantastic gain on this assessment. So the green there is highlighted. They actually had an excellent change in the Fuglemeyer assessment, which is one way that we assess function following stroke. These folks changed by 10 points as a group. That's amazing. That's an amazing amount. So how did they do it? After 6 weeks of therapy at that mid-treatment point, we see that these folks have received 150 hours of therapy in 6 weeks. If you're a stroke survivor in this group, or if you're a therapist in this group, think back to if you have ever provided 150 hours worth of therapy. That's 150 visits. Have you ever received or provided that much care? I know that I have not. In the post-treatment, so after 12 weeks, they had received 300 hours of therapy. Okay, so that's 5 hours of therapy per day, 5 days a week of this, advanced tech therapy. So has anyone ever received or provided that much? I don't think so. So we're talking about repetition. We're talking about how many times someone's arm is moving. If they're doing 300 reps an hour, are they getting 45,000 repetitions? Maybe, but that's how they got the change, right? Okay, in reality, we are also talking about 60 car rides from home to the hospital facility for 5 days a week of therapy and getting back home afterwards. So 60 car rides, okay? There's also a lot of care partner time and effort to get you there, right? Making sure that someone else maybe is picking up the kids while you're at therapy all day, or making sure that you have someone else who's helping to pay the bills because you're not at work, making money during that time. All right, so it is 6 full weeks during this intervention spent, 12 weeks spent out of work, away from home, and out of your family routines in order to do therapy. So to get this result, these folks had to stop life in order to do therapy. That's a costly model, right? It's emotionally costly to do that. There's also, in this study, they didn't show any carryover from moving the arm to doing tasks at home. So are we missing something here? And they estimated that this model would cost $5,000 per person. That person would need to pay $5,000 in order to pay for that much therapy, right? And that's cheaper than what some people might expect because they were sharing the therapist. So one therapist to 3 patients, the cost would be $15,000 for all 3 of those folks. So an interesting model. Boy, people got better. Is it reasonable for actually providing this kind of model? It also requires things like the hospital to have all of those technologies and a place to do the therapy. So lots and lots of challenges to get this kind of model out of a research lab, which is where it took place, and into real life. Okay, so that's, again, something that we're trying to do here at Imago Rehab is take those principles. People need lots and lots and lots of therapy. They need interesting things to help them move their arm. They also need to attach that movement to daily life. Okay, so I'm revisiting our model here. Let's learn some really amazing things from the research, but also we need to put it in practice in a way that is affordable and a way that is possible, right? Okay. So what did we learn? People need more rehab. They need lots and lots and lots of hours of rehab in order to get better. They also need that rehab to be, they need rehab to be better than the status quo. Some exercises or being stretched on a therapy mat is not going to make someone's function better at home. So we need to provide them with better therapy, such as activity-based therapy. And truly, we believe that rehab needs to happen at home because that is where people are living their life. We don't want them to stop living in order to do therapy. We want their life to become more therapeutic. And if you've got questions as you go, pop those into the chat so we can answer later. I'm going to show a video that really, let me switch gears for a second. So I'm going to talk about some of the technologies that might allow us to make this type of therapy a reality. So I spent about 4 years as a Harvard University researcher in the biodesign lab, which is part of the John A. Paulson School of Engineering and Applied Sciences. And so in that experience, I was working on wearable soft robots. And so that is really kind of how Imago Rehab got started. So some of these have sound and some of them don't. I hope the sound comes through. If not, I can make sure that if you're not able to hear it and you want to hear the video, I'll make sure that just email me at the end, and I'm happy to send out links. These are all available on YouTube. So I'm going to explain a little bit about how a robot might be kind of different than what you're thinking of when you think about a robot.
Software robots to both enhance and augment the ability of healthy individuals. And then we're trying to apply the same technology to people who have some kind of physical disability. Historically, when people have designed wearable robotics, they've tried to think about how do we give them superhuman strength. What we believe is that there's a lot of people with some kind of disability who don't need superhuman strength, but just need a small amount of assistance. But that small amount of assistance can have a pretty big impact in their quality of life. So we're trying to take a new approach and say, how do we design new robotic components that are using soft materials to be able to apply forces to a person and without the mass and the kinematic restrictions associated with rigid devices?
There's a potential to really help people who have severe injury.
It's taking an unconventional approach, not saying, okay, how do we improve on the status quo? It's saying, how do we basically take a fundamental leap?
Push all these different fronts, but some.
Okay, I'm going to pause that there. So the person speaking there is Dr. Connor Walsh, who is the primary investigator for this biodesign lab. And a couple years ago, he was looking for an occupational therapist to help with robotics for stroke rehab. And so our worlds collided, and we've been in partnership since 2018, working on wearable robots for home-based stroke recovery. So he's one of the co-founders with myself and one other person at Imago Rehab. So have been very grateful to be part of that. Excuse me, to be part of the biodesign lab and being able to start Imago Rehab off of that. Excuse me. So I'm going to walk you through sort of the research base and where we've come and where we're going with two different devices here. So with the soft robotic glove, that is on the left side. It's a wearable for trying to change hand function. And then on the right side, there is a upper limb or like arm assist device. We also call it a robotic shirt. So that is basically a wearable shirt that has robotic components that are going to move the arm around. So I will explain a little bit about the research that's happened with both of those. Okay, so we see this phrase up here about pneumatic actuation of the hand. So that is taking pressurized air and using that to move the hand. So the way that the soft robotic glove works, and again, this is all published information, is that we have inflatable chambers, essentially they're balloons, and they are sandwiched in between fabrics that either stretch a lot or fabrics that don't stretch hardly at all. So when these soft robotic devices are on your hand and they're not inflated, they just feel like sort of like a winter glove. And then when they're inflated, there's something safe and comfortable that happens. So we're inflating balloons on top of the hand. And so that is quite comfortable. Doesn't feel like much is happening when it's on, which is one of the benefits of soft robots. We call that transparency. So it has kind of is sort of, when it's not on, you don't really notice it. And when it's powered, it's comfortable and soft. And then lastly, it mimics the biologic structure. So we're not imposing what's called kinematics or movement onto a joint. We're just supporting the joint in the way that it's supposed to move. So that on the right side, you see what we call there is the balloon sandwich. So we've got one balloon for opening the fingers, one balloon for closing the fingers, and then just fabric that are encasing those balloons to help guide the motion once they're inflated. All right, so I believe this, I'm going to leave the sound off of this one and just talk through. Yeah. So I wanted to give kind of a video that shows a bit about how we have people use this. We have very, very limited quantities of this, and they're being, its effectiveness is being studied under a research protocol through Imago Rehab. And yeah, so this came out of Harvard. So yeah, so we have folks basically use this tabletop system in their home. Helps give them some data, which is really important. And we use that to, help them figure out how much more movement they could do. And then like tying that movement back to activities that are in their home to really create that rehabilitation loop. Good. Okay. All right. So give you a little bit more explanation of sort of what we've done researching this device. So a number of years ago, so this was a study published in 2018, which means the work was done between probably 2015 to 2017. This is really when the project was just getting started. And the population was actually spinal cord injury. So if you look at the gentleman that's there in the green shirt, he's very clearly had a spinal cord injury with his hand positioned in that way. So he is trying to hold onto a coffee cup and hold onto a can of soda during the Jepson-Taylor hand function test. You can see in the top picture there that he's very clearly not able to hold on to the can. He's only sort of cradling it because he doesn't have grasp. So what the glove did for him in that picture below is he's able to actually grip onto the coffee cup and hold it against gravity. So the glove, when it was initially designed for individuals with spinal cord injury, was really designed to give a tighter grasp to those folks. So the study was done with 9 individuals with cervical spinal cord injury, and they noticed a 30% improvement in their ability to manage objects. Also, at that time, if you look in the top picture, the researcher was the one turning the glove on and off. So they had to tell the glove when to turn on. So later on, and I was actually a part of this study here at Harvard, and it was published in 2020. We worked with 13 individuals with spinal cord injury, and we had them also utilize the glove for these daily living type of tasks in a different test. This is in the Jepson hand function. Sorry, the other one was Toronto Rehab Institute hand function test. Anyway, in this one, we found that folks were able to improve their grasp by 2 pounds with the glove on. So when the glove was powered, they could hold an item that was 2 pounds, which is really great for daily life activity. They were also able to see a nice change in their range of motion when the glove was on versus off. And they were 50% better at holding objects. Another change here is that the glove was controlled by the user. So you can see that big red button. So actually this gentleman is powering the glove on and off when he wants to using the button, sorry. At that point, we began to modify the soft robotic glove for the stroke population. So instead of needing a tight grasp around an object, we actually needed their hand to get open because that's the problem we're trying to solve. We're trying to solve that tight hand, can't get it open in order to put it on an object. So we want to push that hand open, which is what you see there in the picture. So we had to really redesign how the glove is created and also what it's supposed to do. So really changing how those balloon actuators work. I don't expect you to be able to read this. If you do want to read it, I'm happy to send you a copy. This was a poster presentation we did at the American Congress of Rehab Medicine in 2020. So we did a pilot study. We had 4 individuals with stroke use our device really only over 6 sessions. So not very much intervention, but just figuring out, did we see anything? And we did see that their hands got a little bit looser and that their grip strength, their active grip got a little bit stronger. So those were positive. So we kept going in that direction. The next study is still in review. It is hopefully going to get published in the next month, which is really exciting. We hope that this will get published. But we had 12 individuals with stroke use this device at home for a month at a time, and they could use the device as much as they wanted to. So they took that setup, that soft robotic glove setup, put it in their home and utilized it as often as they wanted to. And then we provided them with some tele-rehab based check-ins and a home program. And we did see positive changes in hand and arm function. I'm not going to report specifics until we get it published, but fingers crossed that's coming really soon. So keep an eye out. Good. And then I want to explain to you a little bit more about pneumatic actuation of the arm, which is again using those inflatable chambers to provide assistance to the arm, sandwiched in between fabrics that are either stretchy or not stretchy, flexible or inflexible. Okay. So I'm going to just talk a little bit through. So this is an image of the soft robotic shirt. The blue part is the inflatable part. The red part is the inextensible or non-stretchy fabric that acts as a bit of a harness, and then also having some adjustability there. And then I'm going to demonstrate how I might use this as I work with a client. So in the video on the left, the person is wearing the device, but it's not actually turned on. So I'm having to use both my arms to provide like a stretching protocol to this person or a movement intervention, say in the clinic. Very clearly, this is a university lab setting. In the video side on the left, the device is actually powered and holding his arm up in space, so I can use both my arms to facilitate the movement that I want. Keep going here. All right. So there's a bit of explanation here. So we did also find this little graph in the middle here is showing that when the device was powered on, we did note that our participants were able to lift their arm either out to the side or forward 10 degrees more than they could usually. So if they could lift their arm to 45 degrees with the device on, they could do 55 degrees, which lends itself towards more study always. And gets us to the next slide. I'll show you a little bit more about what that might look like in the future. Here's the next iteration of that device, this kind of phase 2, where we had folks wearing these devices and then also using their arm to perform some daily living tasks, like lifting up this container, such as to the cabinet, or trying to place an object in. We also had them stand up and walk around with this device fully portable. So that's really, that's important, is to get the devices, off of the table and being able to embed them in daily life. And then kind of phase 3, kind of where we're going. Currently, we are applying for a grant with the National Science Foundation to further this study. They've been really supportive of the biodesign work so far. And so we're hoping to continue this study. You see on the left there is kind of that in lab only, where we're using the device on someone's body. And then we have maybe an in-clinic model where someone is using that device to help as they move their arm around in a clinic setting. And then really at the end, their highest level autonomy, someone actually using a device like this in their home as they reach to the cabinet, getting assist, getting that activity-based therapy, getting that daily life type of therapy. That's where we see ourselves going. So Wyss Institute, if you've never heard of that, is a independently funded research institution at Harvard University. It is funded by Hans-Ort Wyss, and he has helped to fund incredible amounts of science out of this Wyss Institute at Harvard. So soft robotics and the other robotics portions were part of the Wyss Institute, and we received a lot of support from them. But one of their important quotes is that discoveries can never change the world if they never leave the lab. So the Wyss Institute, really supports the startup culture. So they really want these interesting and disruptive innovations to get out of the lab setting. We can't help people if we never actually make it out into the world. So that's where Imago Rehab is right now. We are one of 55 startups out of the Wyss Institute over the last, I think they've been around for only 10 years. So we are called a Lumineer company. We're one of the Wyss Institute companies. The Wyss Institute startups have created over 1,700 jobs. and have received $2.2 billion of startup venture capital funding. Not all to us, of course, a very small amount that we're working with right now. But the Visa Institute has been definitely instrumental in getting us, as they say, out of the benchtop and into the world. So Imago Rehab launched in 2021. Initially, we were providing only self-pay occupational therapy services in Massachusetts, but now we are providing virtual occupational therapy for adults with stroke and other neuro conditions in 6 states. And we are expanding our service lines to provide speech and PT, as well as expanding our footprint in the United States. We're covered by Medicare and some commercial payers, and we're piloting a variety of home-based technologies, including our glove, which, as I mentioned, we have very, very limited quantities of. We're also providing those digital therapeutics that I mentioned before. So instead of that paper-based home program that you're going to lose before you get home, we're really supporting that in a digital model. So you don't have to worry about losing your paper or not being sure what to do. We have that in a digital form. We also provide virtual support and engagement. We have some virtual support groups, as well as gamified therapy. So we are doing a pilot with RX Games, which is a virtual gaming platform, so that folks can actually use really high quality gaming graphics at home. And there's upper limb, there's lower limb, and there is full body movements that can be utilized right from someone's tablet or computer at home. So this is a really exciting pilot for us. All right, and so I'm gonna kind of tie it back to our good friends, Susan, Jack, and Maddie, and talk about how kind of their stroke recovery journeys inspire me, and some of the lessons that we can learn from the 3 of them and the work that they put into their recoveries. They are all going to be along the themes of high dosage, high intensity, and high interest, as I mentioned before. Okay, so first we have Susan, who, if you remember, is a professional violinist. She came to us after about 18 months of having a stroke, and she just had not really seen any recovery in her arm. She wasn't able to do anything useful with it. She couldn't move it. And she had been trying. She had been going to some therapy, a couple different places. No one that was a neurologic specialist, because her area didn't have anyone for her to go to. She was more going to like a sports therapy type of place, and they really weren't sure how to help her. So one of the main changes we made to Susan's therapy experience is to embed her therapy in daily life. So she began to utilize her arm, not perfectly, right? She's not waiting until she gets better to use her arm in daily life. She is using her arm in daily life right now. So she's using these basic skills like getting her toothbrush to her mouth, getting a little piece of candy to her mouth, brushing part of her hair, right? And opening the refrigerator. She's not waiting until she's better to use her arm during daily life. She's finding parts of her daily life that are allowing her to do useful therapeutic repetition, right? So your daily life affords countless chances for movement. Your life is your therapy. Don't want to wait for your therapy sessions to work on movement. Every day, many, many times of the day is when you need to embed that therapeutic experience into your life. I'm going to click forward. It's probably going to try to play all these again. There we go. Okay. So I want to challenge folks to think about your house as a therapy gym. Okay, so I've got a list of all these different activities that someone might be able to use their arm for. They might be able to use their arm for holding down the toothpaste. They might be able to use their arm for steadying the paper while they make a grocery list. They've got all these different tasks they can do with their arm. And I want them to think about their house and say, when and where in your house can your arm be therapeutic to you? Let's not miss those opportunities. Let's actually involve our arm before it's better it's the way to get it better is by using it more often. Okay, so that's kind of lesson 1, A and B, is about dosage. How can you get more movement out of your arm? So it's kind of thinking about that model that was in Florida, right? And they had 5 days a week, 5 hours a day of therapy. It's not reasonable for any program I've ever heard of, right? But your life can be therapeutic. So your life, you can find many, many, many ways and times for your arm to be therapeutic in your daily life. Okay, then we're gonna look at Jack's story. And Jack's story to me is that therapy is hard work. Therapy is intense. So I'm gonna give you just kind of a little backstory on him. He really was not experiencing much hand function. At this point, he had he'd been discharged from inpatient therapy. He was working in outpatient, and just nothing was happening in his hand. And after we worked with him, Jack began to see some really impressive changes in the hand. So it was really, really encouraging and really wonderful. So these are great changes following stroke, right? Going from not being able to open your hand to being able to make different shapes, tie your shoes, all those things are fantastic. But that's not enough. The next one. Okay, so lesson number 1, if you are not sweating, you should be. I don't think I'd ever seen someone do the activities that I've seen Jack do as part of his therapy protocol. So he went rock climbing at the recommendation of his neurologist. Of course, he has quite a lot of function. You can see him, right? Not everybody is capable of rock climbing, but not settling and not being scared to try things that are seemingly outside the norm, right? So he did things like dance therapy, he did rock climbing, horseback riding, all kinds of things that are challenging and a physical workout in order to get his body moving better. Play the next one. Again, sweating, right? So he's doing really hard, physical, intense workouts. And I want to pause there for a second and say, lesson number 2 is you need a buddy. He's not doing this stuff alone. So if you don't have someone who's helping you, someone who's keeping you accountable and wanting to work out with you, that's a really important lesson to learn. And then I want to watch one more. I'm going to pause that music. So this is his 5:30 routine in the morning. I didn't get up at 5:30 this morning and work the heck out in my basement like he does. But if you're looking for inspiration in your stroke recovery journey, this is a good place to look. So he is, intense exercise, working hard, keeping that body going, not settling for the recovery he experienced initially. There we go. All right, so one more, and then I think I'll be just about done and can take some questions. And I'm running out of time too. So one more, Maddie. Maddie is not an Imago Rehab client. She is an AVM survivor, a world traveler, an author, and a social media influencer. I need to go a little bit faster. I didn't realize how long I'd taken. So I wanted to show these videos of Maddie using many, many, many kinds of technology. Her therapy is not the same every day. She uses lots of different things in order to keep working on her stroke recovery journey. So in these 15 seconds of videos, there have been about 7 different technologies that she's using. And those were just ones that are on her Instagram page. So she has used many, many types of technology, and she keeps using different technologies and techniques in order to make her brain change. So that is here lesson number 2. Don't expect new results while doing the same old thing. Trying new tasks and new tech in order to make your brain better. And then I have a little bit more of that activity-based work that Maddie does. She is, never giving up, never stopping. She tries so many things with her arm. No one else is going to care about your recovery as much as you will. So you have to keep pushing, and you have to keep trying new things and being willing to try things that are not perfect. She still has impairments here. If you look at her in these videos, she's still showing an impairment, but she's still doing it. The way to get better is through, right? So she's not waiting until her arm is restored to zip her jacket. She's using that impaired arm to actually participate in the task such that it will get better. I think there's one more good one on here I want to show. Yeah, she's got painting. You can see she's using splints there too to help her at home. So keeping, if she wants her wrist position, she's using a splint. Okay, I included that last one on there for a reason, because she is not waiting to share her story until she's all the way better. She's willing to share those challenges and missteps and failings too, because they are part of the journey. So as we rethink rehab, people need more rehab, people need better rehab, and rehab needs to happen at home. And we are committed to making that vision a reality. So I think I will stop my share, and there's a couple questions there in the chat.
We have some great questions in the chat if you want to tackle those.
Okie dokie. All right, let me look through. Good. Okay, so Nadia asked, are most home-based therapies for fine or gross motor deficits? So at Imago Rehab, we have worked with folks from age 18 to age 85, and people who have essentially no movement at all to people who have only fine motor deficits. So I think this is kind of a looking at rehab in general. Rehab needs to be accessible to you. Maybe that's over telehealth. You know, are you able to take the tasks and therapies you're learning in a clinic and translate them to your daily life where your body is all the time? If that's not happening, if that transfer is not happening, then, you know, potentially looking into home-based therapy might be effective for you. It's the carryover that makes a big difference. How would a patient be able to access these devices? 2 primary Harvard-based hospitals we do therapy at do not have access. Right. So some of these devices are like the shirt device is a study at Harvard. So Imago is like a partner in that, where our clients are going to have access to that research study. But also, if you want to contact me, I can put you in touch with the researchers at Harvard who are doing that work. I would be happy to pass that on, because some of those, yeah, they haven't left the lab yet, right? They're not on the market, so they're still in the lab setting. And then for some of the other home-based devices, I believe there's someone else on this call, I believe is from NeuroPhoenix. I think I saw a name. So there's lots and lots of companies that are promoting home-based rehab. So I think, I don't know if what's the best way to get all the information to you right now, as we have like 4 minutes left in our webinar, but I'd say like email me.
We can send out, and we can send out whatever you want to send out to all of the attendees as well, if that would be helpful.
Yeah, there are, you know, a variety of companies that are recognizing this and saying it's hard to get people to the clinic, and if they're in a clinic with, you know, 20 technologies, how do you know which one you're going to get access to? So there are a lot of companies that are working on bringing devices to the home. We're one of those. Megan had a question also, if these have been used, if this has been studied in pediatrics. It has not yet, but that is definitely part of the plan, such as kids with pediatric stroke or maybe the CP population. I think these would be absolutely useful, but has not been studied yet, partially because Harvard's IRB, which is the group that governs the research, says 18 and up. So we weren't allowed to work with children for the studies that we were doing. But I think that we should. So we'll get to that. And a question on, let's see, the intensity of therapy when the AVM still exists. That is a great question. And I would say I don't have a really specific answer for that. I'm sure there would be probably parameters set by a physician that maybe there's a certain blood pressure you're not supposed to go over, or maybe a certain rate of perceived exertion, right? Like you have to determine what is the level that you're allowed to work at. So maybe something like rock climbing might not be indicated in that, but there might be another way of looking at it, that intensity, like having your arm be very involved in all the tasks that you do during the day. So maybe we don't add heavy weightlifting for you if your AVM still exists. So I think that's like a kind of case by case. And again, I try to mention that during some of those intense videos, saying not everybody is able to do these things, but we want to be mindful that hard work and intention have to be a part of making an arm function better. Any studies on robotics for ataxia? You are, boy, onto something there, because usually people with ataxia are excluded from studies. I will say that at Imago Rehab, we've had a number of clients with ataxia who have really benefited from these techniques. I have some video that I'm allowed to share. And if you look on our Instagram page, there's several videos of a gentleman with ataxia who has had really significant gains. So I'm happy to send you those videos too, if you want to email me. So I do think, you know, the thing that makes this better is repetition, right? It's that dosage. So the things that you can do with your arm, you should do with your arm. And the things that you want to be able to do with your arm, you need to try with your arm, right? And nothing, not using it is not going to make it. Yeah, these are really great questions. I think I got most of them, right?
I think so. And
Great.
Kristen, this has been fantastic information. We
Great.
appreciate just seeing, you know, where the research has come from and where it's going, and all the practical advice as well. So I hope everyone has enjoyed it. We appreciate everyone giving of your time. I think you got all the questions. So, and feel free to reach out to us if you have any additional questions, and we can get those to Kristen, and we'll share any information she wants to send out as well. We can share with that, and we'll also send out our support group communities as well if you didn't get those in the chat and want to join those if you're not already a part of it. So thank you so much for being here today. And Kristen, we really appreciate your time and expertise and sharing with us. So
yeah, thanks a lot.
Well, I think we're right at noon. So great job. We're right on there. So everyone have a great day, and thank you again.
You're so welcome. Bye-bye.